Hello, my name's Tim Walsh. I'm based in Edinburgh in Scotland, and I'm going to discuss the relative merits of dexmedetomidine or clonidine sedation as comparison to propofol in critically ill patients. I have no relevant conflicts of interest. Those I have received have all been managed through my university. I'm chief investigator for a relevant sedation trial, which is funded by the NIHR Health Technology Assessment Agency in the United Kingdom. And I'll describe this trial briefly at the end of my talk. So our context here is that propofol is the standard or default sedative agent in the vast majority of ICUs around the world. But alpha-2 agonists are an alternative agent of potential interest. They may produce superior quality of sedation, they may reduce delirium, and they may have anti-inflammatory effects, which might be beneficial for certain types of patients. And I'm going to discuss the evidence for these over the next few minutes. There are two potential agents. There's dexmedetomidine and clonidine. So alpha-2 agonists as a general drug group act primarily at the brain stem locus ceruleus. That's a different site from classic GABAergic agents such as midazolam, and they generate a dose-dependent decrease in activity of noradrenergic neurons in the brainstem via postsynaptic receptor-mediated inhibition. And via that mechanism, they indirectly increase the activity of GABAergic neurons, which, as we know, are sedative and the primary site of action of propofol and benzodiazepines. Through that mechanism, they alter natural sleep pathways. And in addition to that, they have analgesic properties via multiple sites, primarily at spinal cord level. So the characteristics of alpha-2 agonist sedation is preserved muscle tone and ventilation, often frequent spontaneous and evoked movements of the patient during sedation, easy awakening and arousal in response to stimuli, and a cooperative patient who classically with high quality sedation can obey simple instructions. So clearly they have potential benefits in intensive care. So if we compare the two agents, dexmedetomidine and clonidine, dexmedetomidine is a highly selective alpha-2 agonist with a ratio of alpha-2 to alpha-1 of about 1,600 to 1. Have a license in the EU for sedation in ICU for the last decade or so, and it's very highly protein bound with unbound drug freely crossing the blood-brain barrier. It's highly metabolized in the liver and it has inactive metabolites with a predictable elimination half-life of around 2 hours. Now, in contrast, clonidine is an old agent, originally an antihypertensive. It has about an eighth of the alpha-2 selectivity. It's not licensed as an ICU sedative, and it's much less protein bound. Its hepatic metabolism is far less complete, and 2/3 of the drug is excreted unchanged in the urine. As a result of that, it has a far less predictable elimination half-life, which is much longer, about 7 hours typically, and is unpredictably prolonged by renal failure. And of course, one of the key differences is cost. Dexmedetomidine is more than 10 times more costly per day of sedation in ICU than clonidine, which is why clonidine is an attractive agent if it could demonstrate similar benefits. So what is the evidence for benefit from alpha-2 agonists in relation to usually propofol or benzodiazepine-based sedation? I highlight here 4 systematic reviews that have been published in the last 5 years. They have been undertaken in different ways, but the key findings have been that the only robust evidence is for dexmedetomidine. They have no overall effect on mortality, but they do reduce ICU length of stay. They can reduce the time to extubation by typically 1 to 2 days in population level, and they probably reduce delirium, but there's inconsistent signals between trials, probably in part related to different populations and also different ways that delirium was measured in those trials. As I mentioned, these systematic reviews have highlighted the lack of evidence for clonidine, and a specific clonidine review published 2 to 3 years ago really highlighted that we have inadequate evidence for the benefit of clonidine in intensive care. I'd like to highlight several studies that have been published since those systematic reviews. The first is this Australian studies done by the ANZEX group, which looked at the benefit of dexmedetomidine compared to placebo in a double-blind manner in very challenging patients with agitated delirium failing to wean from the ventilator. And in this trial, they showed the addition of dexmedetomidine to existing care compared to blinded placebo, reduced time to extubation, there was quicker resolution of delirium and lower use of antipsychotics. This was a very small, challenging study called the Dahlia study, but it really highlights the potential for dexmedetomidine in particular to help us manage these very challenging group of patients. The second is a study in severe sepsis, which was undertaken in Japan and was based on a hypothesis from a post hoc analysis of the MENS trial, which is one of the dexmedetomidine versus lorazepam trials, where in a subgroup analysis of sepsis, they showed a very large mortality difference in the patients included. Unfortunately, this trial was the power analysis and the sample size was based on really what was an unrealistic sample size. And it also had co-primary outcomes of mortality and ventilator-free days, which really means it was unlikely to have power to show smaller but clinically important differences. And what was actually shown was a difference in mortality, which was not statistically significant, but in absolute terms was about an 8% absolute risk reduction. There was no difference in ventilator-free days, but sedation quality was improved with dexmedetomidine, the way it was measured. A secondary interesting publication from this study also showed that dexmedetomidine reduced circulating inflammatory markers, mainly CRP, compared to the propofol-based control group. And then we turn to the SPICE-3 trial, by far the largest trial undertaken and published in the New England Journal last year. This was a just under 4,000 patient study where existing care, which could be propofol or benzodiazepine or whatever the existing sedation practice was in the ICU taking part, was compared to the early introduction of dexmedetomidine with the aim of targeting light sedation. You can see from this table 1 of demographics and clinical characteristics that these were intensive care patients typical of general populations in our ICUs, with a mean age of around about just over 60. The key outcome in this study was 90-day mortality, and this study showed with absolute confidence that there was no overall difference in mortality, and the 95% confidence intervals of the adjusted risk difference show that there was very unlikely to be more than a 3% difference in mortality either way, with an overall point estimate of 0 benefit. However, in this study, 2 key secondary outcomes did show a statistically significant improvement, and that was days free from coma or delirium, which was around about 1 day in a 28-day follow-up period, and the number of ventilator-free days was also reduced on average by about 1 day. We recognize in this type of research the challenge of using ventilator-free days and coma and delirium-free days due to the competing risk of death and the fact that many of these patients only spent a few days, typically 4 or 5 days in many cases, on the ventilator. But there was a benefit from dexmedetomidine in this trial, but it was a secondary outcome. There was no difference in cognitive outcomes or quality of life as defined key secondary outcomes. And one of the challenges with this study was that it was a large international trial carried out in multiple ICUs in multiple countries. And the detailed data about sedation quality and state in the study suggests that in the first 2 to 3 days, light sedation was targeted and achieved far less than was hoped in the original protocol, where the idea was dexmedetomidine would enable light sedation. And this might be a confounding issue in the results, but it is our most definitive evidence. There were some key predefined secondary outcomes, subgroup analyses, and the one of most interest was age. And what they found was that there was a key interaction with age in this study, where patients who were older had a mortality benefit from dexmedetomidine-based sedation, and those who were younger had a mortality harm from dexmedetomidine-based sedation. And I understand the group are doing ongoing analyses to possibly try and explain why this might have been, but it seemed to be a convincing, important subgroup analysis. Of relevance, the sepsis subgroup in this study, who were about 2/3 of patients with a very clinical pragmatic definition, there was no benefit from dexmedetomidine, in contrast to the much smaller Japanese study I presented a few minutes ago. But the definition was quite loose, and it's possible that this might have been a very inclusive group of sepsis patients. So dexmedetomidine as a primary sedative agent, there's no overall effect on mortality. It decreases duration of mechanical ventilation. It probably decreases delirium. No proven mortality benefit in sepsis, and age-related differences in risk-benefit profile seem likely. But of importance, cost effectiveness is unproven, and we have lack of data for clonidine. I'd just like to highlight the role of dexmedetomidine in perioperative practice in much lower dose. And this is a systematic review of published studies that looked at low-dose perioperative dexmedetomidine in groups of patients. And this systematic review clearly showed that in both cardiac surgery and non-cardiac surgery patients, dexmedetomidine did decrease post-operative delirium convincingly and consistently with little heterogeneity. I'd just like to highlight this study, which was a Chinese study, one of the largest and highest quality studies in non-cardiac surgery, which has also published a secondary analysis of long-term follow-up of 700 patients with very high follow-up rates. And in this study, dexmedetomidine was also associated with improved long-term cognitive status and quality of life, which may have been mediated by delirium, although it's difficult to prove that. There was no difference in mortality at 3 years, but over the first 2 years, there was also a mortality benefit. So in peri-postoperative practice, we see that dexmedetomidine does decrease delirium. It has consistent effects in major surgery types and also in younger and older groups. And in the systematic review, there was a suggestion of greater effects with longer infusions, and there may be long-term benefits. So, in summary, for ICU patients, dexmedetomidine decreases duration of mechanical ventilation and delirium, has no overall effect on mortality, but patient-specific effects probably exist, and the cost effectiveness is uncertain. For clonidine, we just don't have enough evidence to know whether it is equivalent to dexmedetomidine in both benefit or safety. And for perioperative patients, we have really quite convincing evidence for dexmedetomidine having beneficial effects for delirium. And just finally to highlight, we're currently undertaking a 3-arm study in the United Kingdom comparing Propofol, dexmedetomidine and clonidine to try to obtain higher quality evidence for the relative benefits of these 3 agents. And we would hope we'd be reporting on that study in about 2 years' time. Thank you very much.